and also for the direct factor 10 inhibitors, and lastly for the dabigatran, which prevents the action of the thrombin on the fibrinogen, converting it into fibrin. Therefore, this leads to its anticoagulant effect. The benefits, as all we know, is simple to use, is not subjected to much interaction, do not require routine monitoring, and have rapid onset and rapid offset as well. These benefits do not come as an expense of the safety or efficacy. The pivotal studies for each of these agents show at least equivalent, and in some reports superior performance to the alternative conventional agent. The medicinal products under investigation. This makes the extrapolation of the results on the open world is skeptical. Post-marketing studies have filled the gap left behind the clinical trials being conducted in the real world under the actual conditions and circumstances that the patient will confront. Post-marketing studies as well as the clinical studies were congruent to each other and vouching the safety of the dabigatran in terms of the risk against major bleeding as well as the risk of intracranial hemorrhage. Both of them were vehemently lower than that of the vitamin K. Although they are much lower than the vitamin K or the vitamin K antagonist or the warfarin, quarter of the patients on the direct oral anticoagulants will discontinue its use within 2 years for emergency surgery. For that reason, the absence of a clinically approved reversal agent for the direct oral anticoagulant has tempered the enthusiasm for its use among patients and physicians. Given short half-life as compared to the vitamin K antagonist, which reaches up to 40 hours, and the lower risk of the bleeding than the warfarin, as you see, which can mount to 19.2% of the treated patient. 1/3 only of bleeding can be managed without any blood products. However, reversal is deemed necessary in the following circumstances. Number 1 is a serious bleeding. Number 2 is emergency surgery or intervention. Number 3 is trauma, was accidental or deliberate overdose. The International Society of Thrombosis and Hemorrhage had defined the serious bleeding as follows: this is fatal bleeding like the exsanguinating hemorrhage, symptomatic bleeding critical area like the intracranial or intraspinous or intramuscular or intraocular and pericardial, or any bleeding that leads to full of 2 grams of hemoglobin BDL or necessitates transfusion of 2 or more of whole blood or packed RBCs. What about the reversibility of conventional agent and DOAC? For the reversibility of the vitamin K antagonist, vitamin K itself is not the preferred reversal for the vitamin K because the warfarin inhibits the vitamin K epoxide reductase permanently. Therefore, the reversal of the warfarin depends upon the generation of the new vitamin K hydroquinone, and therefore vitamin K dependent factor, which takes 1 to 2 days to build up again. Fresh frozen plasma is effective but dose dependent, and the hypervolemia can be reached before adequate reversal is attained. Prothrombin complex concentrate is present, or it is present in 2 formula, 3 factors or 4 factors. It's effective to revert the action of the warfarin and its active counterpart, which is activated prothrombin complex concentrate. However, the thrice have higher thromboembolic incidence, reaching up to 7.8% for the prothrombin complex concentrate, and 4 to 8 events for every 10 injection of the activated prothrombin complex concentrate. the non-specific reversal of the direct oral anticoagulant. Simple discontinuation of the direct oral anticoagulant is effective in almost all minor bleeding, such as skipping one single dose. The activated charcoal interferes the absorption of the direct oral anticoagulant when ingested during the last couple of hours. Hemodialysis can clear 64% of dabigatran after a session of 2 hours. After a session of 2 hours hemodialysis, and can clear 68% after 4-hour hemodialysis session. But for the other anticoagulants being attached to the plasma proteins, factor 10, activated factor 10 inhibitors are unaffected by the hemodialysis. Hemodialysis utilizing charcoal filter is being investigated. The use of procoagulant, in irony to their effectiveness in the vitamin K reversal, their putative reversal effect in case of the direct oral anticoagulant should be viewed with skepticism. Data are derived from the animal studies, in vitro and ex vitro human volunteers. The results did not escalate to be eligible for in vivo human studies. In short, their effect on the coagulation parameters is heterogeneous, and it does not correlate with stop or cessation of the bleeding. I'm sorry for that. This is a rundown on the effect of the coagulant, effect on factor 10, activated factor 10 inhibitors, reversal in animal models, vitro, as well as their results, the dabigatran. Combined, the first of its kind, grant FDA and EMA approval as a specific reversal of the dabigatran, has now been used in the United States, Canada, Europe, and European Union, and also the active ingredient is idarucizumab. This is a humanized monoclonal antibody. It's a fragment antigen binding portion, specifically binds to both free and attached to the thrombin dabigatran. The fixed portion of the antibody, which is a fragment crystallizable, is removed. Also, the complex, resultant complex is very stable. It lasts for more than 260 hours. Of it disappears completely from the circulation, so that you can administer the groups of the patients who are included emergency surgery, in need of emergency surgery, and patients with serious 6 hours. Thank you.
A study that has been conducted 5 years ago, but I think it was never, and overall 227 surgical patients were at high risk. Actually, the more striking patients, you will see that only 1/3, in spite of 1/3 of them on both arms, the surgical arm and the medical arm, received the proper prophylaxis against VTE in hospital while they are at high risk. So that was a very representative kind of study. Just been saying nearly one-third only received the proper prophylaxis, and prophylaxis was with heparin, and mechanical prophylaxis was seldom used in fact. Although you know and I know that some category of patients are candidates because of their bleeding tendency or whatsoever, or imminent surgical procedure, they are candidates for mechanical prophylaxis, but this is another issue. Conclusion of the study was that in Egypt, one-third of hospitalized patients in pending surgical procedure or having acute medical condition are at high risk, and again, one-third of them receive the proper prophylaxis. So that's the situation. What about the post-discharge? Because once the patient has undergone the procedure or has been past the initial medical condition, the acute medical condition, he is in need of further what we call extended prophylaxis. And to our astonishment, Professor Tara Abdel-Azim was just telling me that a lot of our junior colleagues are not quite aware of this necessity to have an extended prophylaxis while at home. Do we really have a consensus? Do we all agree in all our centers on which drug and in what dose and for how long shall we be using single or more than one drug? The answer is simply no. We do not have a common consensus actually for that. So if we look at the three major trials, I'll be very quick on that, that tried to give us some answers to this very critical issue. Start by the Magellan study. I'm talking about mega trials. So more than 8,000 patients. Randomization between enoxaparin with oral placebo or subcutaneous placebo with rivaroxaban. Exclusion criteria were the usual ones you're aware of. The endpoints were efficacy. 10 days is non-inferiority. That was an arbitrary decision by the trialists. 10 days is non-inferiority. 30 days or more is superiority, by the way. And safety outcomes. So here are the results. I'll go again quickly. The conclusion of the Magellan study that rivaroxaban was non-inferior to enoxaparin. However, it was associated with an increased risk of bleeding when we are talking about extended prophylaxis. Extended prophylaxis, by that we mean 6 weeks or more. The Mariner study, again, more or less, randomization, now talking 12,000 patients. Rivaroxaban, orally, of course, for 45 days, and placebo for 45 days. Again, the same more or less exclusion criteria, endpoints, efficacy and safety, and there again the conclusions. Now, this study in particular, rivaroxaban was a significantly lower risk of symptomatic venous, combined, the endpoint is a combined episode of VTE with death, okay, due to the venous thromboembolism or major bleeding. It was low in this particular study. Finally, the ADOPT study, 1,500 patients, apixaban with subcutaneous placebo or enoxaparin plus the placebo, ultrasounds, and duplex and discharge, and at 30 days, the conclusion, rivaroxaban was not associated with significantly lower risk of symptomatic venous VTE and death. The incidence of major bleeding was low. What do we conclude from that? Again, primary efficacy and safety. Very simple. Our conclusion is that we are having controversies, and controversies. And that is why we do not have in Egypt a consensus, all of us, actually, because the data in those mega trials are still confusing. So, common sense dictates, Mr. Chairman, and I'm concluding that we have to tailor our prophylaxis for this high-risk group of patients individually. For each case, we cannot copy-paste a standard treatment that applies to all these high-risk hospitalized Egyptian patients. Now, has the situation, this is a million-dollar question, and I'm concluding with that. A million-dollar question, has the situation changed since 2013 till now? I do not think so, because we keep getting feedback from our medical departments and other subspecialties in the surgery department. In conclusion, ladies and gentlemen, more than 1/3 of all our hospitalized patients for acute medical conditions, even sepsis is an acute medical condition. Heart failure is an acute medical condition. These are high-risk groups by default, okay? Or those for an emergency surgical procedure do not...
Thank you, Dr. Ahmed. One of his elegant lectures as usual. Now we are moving to the next speaker, Dr. Amr Abu Rahma. He will give us a short track of how can we best treat our patients with DVT.
Thank you, Mr. Chairman. Dear colleagues, today, before talking about DVT, I want to ask you 3 questions. How often do you change your phone? Every year? 2 years? Okay. How often do you change your car? 5 years? 10 years? How often do you change your home? 20? 30? If you will have a second wife? The treatment of DVT remained unchanged for 50 years, since the introduction of warfarin in 1940s till the appearance of NOACs. So, which is best? Is it the old therapy or the new therapy? The answer of this question is not our title today, but it is only a small part of it. Our title today is how can we best treat a patient with DVT? And to answer this question, many underlying questions needs to be clarified. Which is better? It is bed rest or ambulation? Thrombolysis or anticoagulation? What is the optimum duration of therapy? To wear stocking or no stocking? And how to estimate the recurrence after treatment? We all know the most dangerous complication of DVT is pulmonary embolism. And to avoid this complication, you usually instruct your patient don't move to avoid the thrombus. But this is against the guidelines and against this systematic review, which concluded that there is no significant difference between ambulation and bed rest for the development of pulmonary embolism. Also, the ACCP guidelines recommended early ambulation over initial bed rest. But in the remarks of the ACCP guidelines, they stated that if the edema is severe and the pain is severe, ambulation can be deferred for a while. After the initial treatment of DVT and the patient is relieved from symptoms, he usually asks a question like Professor Dr. Adel said, is the thrombus completely cured? And here comes the question, do our medicines cure the disease? We all know that anticoagulation, which is the mainstay for treatment of patients with DVT, only interrupts the thrombus progression, but not actively resolve it. And in the journey to find the cure, thrombolytic therapy appeared, and appeared to offer more benefits than standard therapy. Of course, if you have a therapy which thrombolizes this thrombus and preserve the valve function to prevent this kind of complication, it will be an awesome solution. And to evaluate thrombolytic therapy, a trial was conducted, which is a ATTRACT trial. It was conducted on about 700 patients for about 7 years duration. And the conclusion of the ATTRACT trial The conclusion of the ATTRACT trial was that the addition of early pharmacomechanical catheter-directed thrombolysis with DVT, we suggest anticoagulation therapy over catheter-directed thrombolysis. So, which type of anticoagulation? Is it the old therapy or the new therapy? The ACCP guidelines 2016 suggested the use of NOAC therapy over vitamin K antagonist as the initial therapy for DVT. And they named the 4 FDA-approved drugs, which is rivaroxaban, dabigatran, apixaban, and edoxaban. And now, which NOAC and for which patient? The ACCP guidelines also stated that in the absence of direct comparisons between DOACs, no preference for one DOAC over the other. And many trials was conducted to evaluate these drugs, and all of these trials was conducted against warfarin and not against each other. So there were no head-to-head studies. But recently I found this study this year, which was conducted in this year, and comparing between rivaroxaban and apixaban, and also there was no significant difference between both drugs. Now the urging question, which is more safe and which is more effective? In the Einstein study, which was supported by Bayer company, the rate of recurrence was less with rivaroxaban than standard therapy, and also the rate of major bleeding was significantly lower with rivaroxaban than standard therapy. So from this study, rivaroxaban can be considered safe and effective. But for which population? And what about frail patients? The patients who are old age, with low body weight, and the patients with renal impairment. What about these patients? These patients are more susceptible to bleeding complication during anticoagulation therapy. Also, this Einstein study, we can found that rivaroxaban decreases the risk of major bleeding in fragile patients by 73% versus the standard care. So you can use rivaroxaban more safe to fragile patients than standard therapy. Also, in cases with mild and moderate renal impairment, the rate of bleeding was less with rivaroxaban than standard therapy. Moreover, you don't need to change the dose in cases of mild and moderate renal impairment. And in case of severe renal impairment, when creatinine clearance is less than 30, you can only decrease the dose from 20 milligram once daily to 15 milligram once daily. And by the way, what is the dose of rivaroxaban? It is given as initial loading dose for 3 weeks, 15 milligram twice daily. Then we continue with 20 milligram once daily. Why 3 weeks? All anticoagulant therapy for 7 days, 10 days, but the first time I heard 3 weeks. And searching for the why 3 weeks, of course this is not the answer, but the answer is that recurrence rate is very high in the first 3 to 4 weeks. So it is better to load the patient with a high dose in this area. When you should avoid new oral anticoagulants, if the patient is pregnant, if the patient is in dual antiplatelet therapy, or if the patient had cancer, still low molecular weight heparin is the recommended by guidelines for the treatment of cancer patient. But there is a study comparing the role of rivaroxaban versus dalteparin in cancer-associated thrombosis, which is the SELECT-D study. In this study, the rate of recurrence was less with rivaroxaban, and the rate of fatal bleeding was similar in both groups, and the rate of major bleeding was a little higher with rivaroxaban. How long to take the treatment? Before calculation of the duration of the treatment, some terminology need to be clarified, which is the long-term anticoagulation refers to the first 3 months, and extended anticoagulation when there is no scheduled time to stop. Also, we should know the difference between provoked and unprovoked, also proximal versus isolated DVT. Of course, provoked with a preceding transient risk factor, and unprovoked DVT with no preceding risk factor, and the patients with active cancer, thrombophilia, and family history can be considered as unprovoked. If the patient has provoked proximal DVT, anticoagulation should be continued for 3 months. But if it is unprovoked proximal DVT with no bleeding risk, you should consider extended anticoagulation therapy. And if there is high bleeding risk, it should be only for 3 months. If isolated DVT with no symptom, you can put the patient on just follow-up with duplex. And if the patient has severe symptoms, you can consider prescribing anticoagulation for 3 months. The ACCP guidelines in 2016 come to us with a weird recommendation, which is the use of aspirin. Before, aspirin was contraindicated in venous thrombosis, but in ACCP 2016, they stated that we can use aspirin over no aspirin therapy to prevent recurrence. There is the Einstein choice, which is comparing rivaroxaban versus aspirin. In this study, of course, rivaroxaban provided superior reduction in the recurrence rate over aspirin. Of course, this is logic and expected. But what was awesome that the rate of bleeding comparing rivaroxaban versus aspirin as extended therapy was more or less similar to each other. The other question اللي دايما العيان بيسأله لنا أنا هتنيني لابس الشراب لحد إمتى؟ The ACCP guidelines in 2012 stated that in patients with acute DVT, we suggest the use of compression stocking. And in 2016, they suggest not using compression stocking routinely to prevent post-thrombotic syndrome. I think this is our reaction to these two recommendations. And if this is our reaction, I think this is the patient reaction. لما العيان يلف على كل دكتور ويقول له أنا شغال ب 2012 والتاني شغال ب 2016. What about the recurrence? In order to take a decision about the recurrence, we can use screening for thrombophilia. What is your opinion about screening for a hypercoagulable state in a patient with previous DVT? Is it a fact or fake? In my opinion, screening for a hypercoagulable state for a patient with previous DVT is like searching for the moonlight during sunshine. Because the strongest risk factor for venous thromboembolism recurrence is the prior venous thromboembolism event itself, particularly if it is unprovoked. And the presence or absence of an inherited thrombophilia will usually not change the decision regarding the length of therapy. And what will change your decision? The ACCP stated that if the patient is male with D dimer positive after 1 month of treatment, it increases the risk of recurrence. And because of the time, these are clinical scores which predict recurrence. In the variable of this clinical score, we can't find thrombophilia testing. In conclusion, early ambulation and treat your patient at home. Use DOAC as the first line in DVT not associated with cancer, and consider long-term therapy in unprovoked DVT, and don't screen for thrombophilia. And this symposium, this presentation was sponsored by Bayer Company, and the treatment was rivaroxaban, the treatment was the other, some bias. Thank you.
Thank you, Dr. Amr. At the end, to clear your again, because this bias is fruitful at the end to clear our ideas, and we will discuss what is with and what's against for every product. Our next and the last for this session is Dr. Ahmed Abdsalam, Professor of Cardiology, Ain Shams University. At this session, he will give us an idea about the anti-active factor 10 class effect or member variability. I was honored to discuss with him some of the value of his talk, and I found that it needs to be heard among this big gather, and he's welcome to share with us his always sparkling ideas. Please, Dr. Ahmed.
Thank you very much, sir. Mr. Chairman, dear professors and colleagues, at first I would like to thank Professor Mosad for his kind invitation to chair actively in this presentation, which will speak about anti-active factor 10. It is a class effect. We can share these all drugs as one member, or there is some variabilities between these different drugs. But first, this is a kind of facts now. When we're comparing warfarin with the novel oral anticoagulants, there is no doubt that there is some superiority for the novel oral anticoagulants over warfarin for the treatments, not only for the DVT pulmonary embolism, but also for atrial fibrillation, non-valvular atrial fibrillations. And we have a good news now. In May 2018, we have a selective antidote for not only anti-active factor 10, but also for the low molecular weight heparin, which is, again, it is recombinant protein that works as an antidote by inhibiting the effect of active factor 10 and low molecular weight heparin. So now we have a selective antidote for these drugs and not only a non-selective forms. Why not? I'm not speaking about active factor 2. I have some problem with these types of drugs because there is something in the concept. When we are inhibiting active factor 10, we are inhibiting perfectly the coagulation profile, as we know that every molecule of active factor 10 is enough to activate 1,000 molecule of active factor 2. So it is easier to inhibit factor 10 rather than to inhibit 1,000 molecule of active factor 2. The other thing is that it needs bridging. There is some problem about the dose and patient compliance. It is twice daily versus once daily in active factor 10. It is a prodrug that needs to be activated, so if there is any problem in the patient that inhibit or interfere with this activation of the drug, there will be a problem with the patient, and cannot be used with proton pump inhibitors because, as I said, it's a prodrug and it needs the acidity of the stomach to change to an active drug. So if the patient is in need to take a proton pump inhibitor, so in these conditions, it will be contraindicated to give dabigatran. And again, and finally, the low bioavailability, which reaching to 6% only. Can we able to compare now? This is a very important question in 2018. Is there any way to compare between these drugs or not? I think no. Why? Because actually there is no head-to-head comparison to compare these drugs with the same variables. Okay, so can we extrapolate from the present trials? I think the answer is also no. Why? Because there is variables in these trials which are different. So if there is difference in the variables in every trial, so how can I compare between different trials? For example, if I'm speaking about bleeding, which is the major interfering with the usage of this novel oral anticoagulants, if we look to this trial or this study, which is a systematic review, it is clear that the rivaroxaban is the most important drug that may cause GI bleeding. It is very clear now. But is it true or not? Let us first put these facts. All the novel oral anticoagulants increasing the GI bleeding when we compare it with the old regimen. And if we compare the two major trials, which is speaking about the VTE pulmonary embolism, which is the Amplify in the apixaban group and the Einstein in the rivaroxaban group, it is appearing that the risk of GI bleeding in the Amplify is lower than that in the rivaroxaban in Einstein trial. But if we are closely looking to the underlying variables, we will find the fact that the number of patients with cancer in the study of Einstein is much than double the number of cancer patients in the Amplify trial, which means that the risk of bleeding with this type of patients with cancer is higher than that in the Amplify trial, and so the risk of bleeding should be higher. So I can take these results at ease. The second important thing is that GI bleeding is correctable. When we look to the rocket atrial fibrillation, which is speaking about the rivaroxaban trial, we will find that the regression analysis putting 3 parameters that affecting the development of GI bleeding in this type of patients, which are the anemia at the baseline, a history of GI bleeding, and the long-term aspirin use. And I think all these parameters can be corrected by correction of anemia before giving the drug if possible, giving proton pump inhibitors, and modifying the dose of aspirin to 75 or 81 milligrams, or stop it, as we know that primary prevention now with aspirin is debatable. And if we look to the post-marketing trials, which is the Xanthus trial for the atrial fibrillations, we'll find that the actual daily life showed that the GI bleeding is much lower than that happened in the rocket atrial fibrillations. And if you are looking to the post-marketing trial that's speaking about the VTE pulmonary embolism, we will find it also much more lower than that happened in the Einstein trials. And finally, is GI bleeding is the only risk? No, sir. There is an intraorbital bleeding. When we compare this systematic review, which is speaking about 102,000 patients taking either apixaban, dabigatran, edoxapan, rivaroxaban, and warfarin, we will find that apixaban with the only novel oral anticoagulants to trend with an increased event rate against warfarin when we are speaking about the intraocular bleeding. So it is not only GI bleeding, there is bleeding in other side which may be more serious than the GI bleeding that can be corrected, like the intraorbital bleeding. So now, how can we compare? We still in the bias. Is this a class effect, or there is some member variability? I think when we try to compare, we compare between the rivaroxaban and the apixaban, because these are the main drugs that are present now in the Egyptian market, with some problems about the edoxaban because it is a Japanese molecule and its present in Egypt is questionable. When we are trying to compare, we are comparing now in bits and pieces. We'll collect it like the puzzle to reach to the final picture. The main point which I speak about it, which are the role of the core, the renal impairment patients, obesity, once versus twice daily regimen, and if they are in need to take aspirin. I will try to be as short as possible. This is a very important trial because it is a comparison directly between the apixaban and the rivaroxaban, comparing the pharmacokinetics and the pharmacodynamics of these drugs, which are the underlying parameter that show us how these drugs are working inside our body. As we know that the pharmacokinetics is the way that the body behaves with the drug, and the pharmacodynamics is the way that the drug behaves inside our body. This design was a randomized, open-label, two-period, two-treatment crossover trial. Very important trial because here is the patient is the control for himself. He will take both drugs with a washout period between them, and we will compare the pharmacokinetic effect of the both drugs on the same patients for a period that lasts for about 1 week in each group. I will pause this. When we are comparing the pharmacokinetics, we will find that there is a significant difference between the peak of the drug when we are comparing the rivaroxaban with the morning and the evening dose of the rivaroxaban. The most important thing, which was very biased to me, that there is a very significant difference even between the morning dose and the evening dose of the apixaban. So even if you are using apixaban, the night dose or the evening dose does not behave as the morning dose, which was very significant in this trial. And when we are comparing as regarding the pharmacodynamics of these drugs, we will compare 4 points. مش عايز اخش في تفاصيل كتيرة علشان الوقت مش هيسمح، لكن اي ثرومبس عشان تتكون بتمر بعده مراحل. اول مرحله اللي هي اللاك تايم من ساعه الانيشيشن اوف ذا ثرومبس لحد الاكتيفيشن اوف ذا common pathway, which is starting with the activation of factor 10, then rising of the thrombin reaching a peak, then decline again under the effect of the fibrinolytic drug. هل فعلا التو drugs دول behave in that manner ولا في difference ما بينهم؟ The first thing is the lag time till thrombin generation. When we compare the apixaban versus the rivaroxaban, we'll find that rivaroxaban is significantly behave better. It prolonged the lag time more than what happened with the apixaban. time to peak again, the rivaroxaban behave better, and the peak rivaroxaban lowering the peak better, and finally the thrombin potential is much lower with the rivaroxaban in comparison with the apixaban. And the final conclusion was, despite similar exposure to both drugs, rivaroxaban 20 milligrams once daily was associated with greater and more sustained inhibition of thrombin generation than apixaban 5 milligram twice daily. Again, the role of the renal impairment, we all know that the renal patient is a very big dilemma between hyperthrombotic and bleeding risk, and there is some guidelines, like the Canadian guidelines does not recommend giving anticoagulants to all patients, so on and so forth. But what the American Heart Association tell us, it tells us that in patients with severe renal impairment, it's not recommended to take apixaban, and you can give rivaroxaban in a dose of 15 milligrams once daily. A very important issue is the use of 1.5 creatinine level to stop or to decline the dose of apixaban to 2.5 milligram twice daily rather than 5 milligrams. It is very interesting to show that once the renal clearance decline from the normal level to just below the normal level, there is prolongation of the half-life of the apixaban drug to reaching about 17 hours, while it is 9 when the creatinine clearance is 60, which means that the bleeding risk is also still higher. What about obesity? This is an abstract which was published in Circulation, showed that the rivaroxaban can be used in a morbidly obese patient without increasing the risk of bleeding, and we know that there is a restriction in the weight when we are comparing with the apixaban, which is around 140 kilograms. once versus twice، طبعا once احسن من التوايس، والاهم من كده مش بس ان هو احسن، كمان في امريكا وجدوا ان الوانس cost effective لان هو هيوفر لهم around $60 million. فدي very important issue. And finally the usage with antiplatelets, we know that rivaroxaban is the only drug which is recommended for patients for secondary prevention of acute myocardial infarction, with the and it can be used with aspirin or aspirin plus dual antiplatelets due to the effect of the APPRECE trial. My take-home message is that, as regarding NOACs, head-to-head comparison is the best way to judge, while not yet available, and I didn't think it will be available anytime. So we have to search for the best by collection of bits and pieces, putting in consideration the drug intrinsic ability, I mean the pharmacokinetics and the pharmacodynamics of the drug, patient compliance, the bridging, and the once daily versus twice daily, the comorbid condition as obesity and renal patients. Complication. أنا بحاول إن أنا يعني أختصر 15 minutes. Okay. Thank you very much.
خليك دكتور أحمد. دكتور أحمد خليك. يعني الحقيقة very conclusive about now it's like a debate between different kinds of DWACs, no molecular way, which is a subject or an issue that raises itself all the time. What we got to use over the oncoming years, what is better for the best of the patient. Now we have multiple varieties of these medications, and we have the standard of care which we used to use in our therapy for many years, like VKA and the bridging therapy and so on. And now we are in a different era. We have to stratify these ideas. First, I have to raise my question, Dr. Ahmed. How would you select the kind of patient by saying you are the kind of patient that needs only single dose therapy? What are the criteria in the patient you would say it is not able for you to use a double therapy? Would you give me a short note? How do you select this kind of therapy by saying you are the kind of patient that you cannot stay or comply with a 2-dose therapy? You need only a single one.
Okay, هو ده يعني it's not my opinion. This is the trial which was done around 600,000 patients comparing over 7 years the once daily dose versus twice daily dose drugs. It was a retrospective trial taking all the patients who are taking the rivaroxaban as a once daily dose versus the apixaban and the dabigatran as a double dose, and they find at the end of the story that the patient compliance is very, very significantly affected by the usage of single or monotherapy rather than using a dual, a twice daily dose. The other important thing is that I didn't show it, but it is very important that the gap, the time that the patient decide not to take any drugs for a while, they find that there is a gap in both groups, but the gap was less significantly in the once daily rivaroxaban or edoxaban drugs when compared to the twice daily dose, the dabigatran or the apixaban drugs.
Dr. Ahmed, it is not this point. I'm asking a kind of patient who used to use the vitamin K antagonist.
Okay.
And you need to switch this patient to one of the drugs. How do you elicit that this patient wouldn't fit for the double dose?
By these facts, I will decide to take once as possible. If there is something that interfering with the usage of once, for example, he has a very high risk of GI bleeding that I cannot interfere with the PPI, I then may prefer to take the apixaban in a smaller dose, or if the patient has a cost-effective condition that interfere with taking rivaroxaban and he prefer to take a much cheaper drug like the apixaban or something like
It's was a kind of interview with some of the patients. They used to ask them, how often do you miss your warfarin intake? And they say, I miss it once a week. And they test for their INR. And they found it to be running in the subtherapeutic range. And then they figure that this patient is not the kind of patient complying with his medicine. So they prefer to use the once therapy for him. This one of the kinds of selection of the patient. Of course, we have a great debate about using once versus twice, but this one of the facts that used to select the proper patient for the proper kind of therapy. My next question would be to Dr. Muhammad Ma'dawi. Dr. Muhammad, you talked about how dabigatran is being in our daily practice, and I wonder, I have my patient with maintained on anticoagulation, which just happened to be dabigatran, and I figured that my patient is 19 weeks pregnant. What do you do? It just happened by chance that she is 19 weeks pregnant and she was on dabigatran. We have to, yes, the microphone please, Dr. Muhammad Ma'dawi. Microphone. Yes.
Giving her birth. If there is a problem in her birth, the authority of the vigilance in the Ministry of Health in Egypt should be notified about this, and they should take their effect. As you know, there is an agency for the vigilance of the drug. That's to say, the license for the drug to be marketed in the market is not for guarantee for forever, and there must be an oversight of this, or to be monitored during its use. The authority which is responsible for that is called the vigilance. This authority must be notified about that, and they must take an action to prevent this to happen in the future.
Okay, is there any studies that support that any of the drugs is safe against the other in the kind of...
No, no. The simple answer for that is children and pregnant women are called the venerable groups. الجروب المقدس. They are not included in any of the clinical trials. But the animal studies which had been performed on all the oral anticoagulant denied their safe use in the animal. Therefore, there is no need to do any further investigations to elucidate this.
I'm asking that because there is only one single study that have shown by accident that dabigatran has been used during pregnancy and it was associated with some anomalies. And there is one single study that revealed that rivaroxaban has been excreted in milk, and one study that showed that rivaroxaban passes through the placenta to the baby.
Yes, all of them are case reports.
Yes.
Because there is no clinical trials.
No, it's not a trial. Yes, yes. My next question would be to Dr. Adil Husseini. Dr. Adil, I have my patient with a past history of upper GI bleeding, and it was just a couple of years ago, and now I have my patient to put her on one of the DWACs. What kind of DWAC do you prefer for such a patient?
هو طبعا عيان جاله جاستروانتستينال بليدنج قبل كده، ما انتش عارف ايه الكوز بتاعه قبل كده، اكيد عملت له منظار وشخصته والعيان ده ستيبل في الفتره دي، فده في حد ذاته عيان ستيبل مش كونترا انديكيشن ان انت تديله دايركت اورال انتي كواجلانت الا اذا كان عنده اكتيف بيبتيك السريشن اور مالجنسي، لان احنا اتكلمنا في المالجنسي دلوقتي.
Dr. Adil, we all concerned about upper GI bleeding,
Yes.
and the same way a patient with menorrhagia or uterine bleeding, and she is on one of the DWACs. Now she has this menses is such in an often way that I have to switch from one to someone else. What do you think? Which kind of DWACs would help this patient during her menses?
هو ما فيش ستاديز قالت ان في واحد من الدواكس بيزود المنستيروال بلاد اكتر من التاني. دي نقطة مهمة، يعني انت ما تقدرش تقول انا اديت ده فانا هعمل شيفت للتاني علشان اتجنب. وبالتالي ما تقدرش تقول ان الدراج نفسه هو اللي بيزود الحكاية دي، فما عندناش دراج over the other increase menstrual bleeding.
Thank you, Dr. Adil. Yes, Dr. Ahmed, اتفضل. Dr. Ahmed له comment.
We are probably losing more time in trying to get from the different speakers straightforward answer, and of course this is a noble target because we need to put in consideration our junior colleagues, but the basic issue in my opinion is that looking at trials to try to get a conclusion that would help us formulate a policy. We are often biased because of the nature of the trials themselves. Meaning that, for instance, your first question was to Dr. Ahmed Absalam was which specific drug would be suitable for this patient. So I tell him, you are now a candidate for only one drug. In response to your question, sir, there are situations that are really self-limiting, and you wouldn't be in such a mess or a confusing situation. For instance, as in my presentation, you are having a hospitalized patient who is about to perform a surgical procedure and he is high risk group. You cannot have the luxury of giving more than one, and this particular one should have a very rather short half-life because he's going to surgery, and so forth. So part of the problem may be not as big as we may figure, but again, for the rest of our unanswered questions, I think we should look carefully to similarity of the trials to get a conclusion. drugs, trials that have primary endpoints that are similar and with exclusion criteria that are similar, so that we could get some meaningful conclusion. That's my opinion. End of the day, we do not have level 1B even evidence of, so far, the superiority, the absolute superiority of one drug of all the NOACs over the others, and the absolute superiority of the NOACs in certain situations over low molecular weight heparins.
Just again with you, and this would be the last comment, to make it straightforward for our group over here, we have to stratify according to the data, according to the guidelines, and according to our personal experience. In flashes, a patient with cancer-related thrombosis, is there a rule for anything?
Yes. This is proven beyond doubt. Low molecular weight heparin.
A low molecular weight heparin. A patient who is going to have a thrombolytic therapy or thrombectomy while in hospital with an impending gangrene, do you recommend to use the wax while the patient would go to the OR at any time?
No.
You prefer which kind of anticoagulation?
Again, low molecular weight heparin.
A low molecular weight or unfractionated because of the short lifeline.
Yes,
antiphospholipid syndrome. Do you prefer which kind of anticoagulation in such case?
Now, for the third time, I feel humbled. I am not the authority. I am just an obedient student who is trying to practice the best way he can. To my knowledge, these are patients who might be benefiting from the DOACs in general. You're talking about antiphospholipid.
Yes.
Among the global group of unprovoked young patients, maybe?
Yes.
Yes. They have usually a poor response in my group of patients to the coumadins or the antivitamin.
Dr. Ahmed Hussein has concluded the idea that having multiple tools in your hand would help you. It wouldn't hamper your business. Having one, moving from one to the other would make you easier to manage your patient from the low molecular way up to the wax or even the old standard of care, which is the VKA and the bridging therapy. Having these multiple tools, they are not competing. They are gathering together to select the best one for the individualized patient. You should tailor your treatment according to your case. This would conclude this session. Please, Dr. Mustafa.
For Dr. Adel, please. Considering now we are in the era of overwhelming DOACs. Overwhelming DOACs. That's the era of DOACs now, as you say.
DOACs.
Is there a place for vitamin K antagonists still or no? In the management of VT?
This is a very good question. Yes. أنا لما باجي أقعد أفكر في الأولد ريجيمن unfractionated heparin بلس فيتامين كي antagonist، أنا بلاقي نفسي ما بستخدمش الانفراكشنيتد هيبرين إلا انترا اوبرتيف، يعني أنا بقالي سنين ما بكتبوش. لما أجي أبص على الفيتامين كي antagonist أنا يمكن دخلت في ثالث أو رابع سنة ما بكتبوش ولا بعمل مونيتور. فأنا شايف إن maybe لظروف أخرى في مجتمعات أخرى ما عندهاش اللكشري بتاع الدواكس. يعني أنا أفتكر إن أنا كنت في السودان ما عندهمش فكرة حتى على اللو موليكولار ويت، مش الدواكس. في مجتمعات كده، وقابلت بعض الشركات اللي هي دكتور عادل احنا بنروح ليبيا والكاميرون ومش عارف فين وفين، ما عندهمش فكرة عن البرودكت، واحنا عندنا ناس زملاتنا بتعمل لونشنج للبرودكتس دي. لكن أنا شخصيا في الفترة اللي فاتت دي قد تكون قصيرة أو طويلة، الأربع سنين دول أنا ما كتبتش ولا ده ولا ده يا دكتور مصطفى في الكلينيك بتاعتي.
I love this kind of discussion because it's a fight now, and everyone is contributing to our brainstorming. I'm glad to hear that.
Even so, لو الدواكس sponsored by the government وبتتوفر ببلاش زريزا بليس وفي كيز. تمام. بليس ده في حاجتين مهمين جدا. تمام. الرينا كليرنس اقل من 15 ده رقم واحد. وفي حاجه تانية احنا ناسيينها، العيان نون ادهرنت تو ذا دراج والاي ان ار بتاعه من 2.5 ل 3 ووقف الدراج لمده يومين نسيها، الاي ان ار على ثالث يوم هيبقى 2.4 نوت ان ريسك فور ريكارنت دي في تي. واي؟ مع الدايركت اور انتي كواجولانت لو وقف الدراج لمده يومين هيبقى اكسبوزد تو ريكارنت دي في تي. فالعيان المهمل ده احسن له، وده كلام ممكن الناس تستغرب ان انا بقوله، تمام، احسن له ياخد في كي. العيان المهمل اللي هيقدر ينسى 3 ايام، لان الاي ان ار ما ينزل من 3 في ال3 ايام ده هينزل ل 2، لان الفي كي اي ليها اكستندد تريتمنت واير كل الدايركتور انتروكراجمنت ار شورت اكتنج.
اضافه رائعه دكتور عمر، لان هي دي النقطه اللي انا باكد عليها. وجود عندي كذا ستراتا انا بقدر استخدم للعيان بنوعيه العيان، فاللي مش هيقدر تستيك مع الميديكيشنز انا هختار له الحاجه اللي تناسبه. دكتور حسام الوكيل عاوز يضيف حاجه. الميكروفون.
واك سيرب.
Yes.
We should insist for this for the young generation. العيان اللي عامل ميكانيكال فالف ريبليسمنت must be contained على فيتامين
واحنا بنتكلم على الفي تي اي دكتور حسام، مش على الفالفولار او ايفالفولار هارت ديزيز، بنتكلم على الفي تي اي. على الفي تي اي. اوكي. دكتور احمد عبد السلام هيعاود الكره.
هو طبعا هو في two types of patients directly will use vitamin K antagonists. الcancer related DVT up till now there is a rationalized to use the novel oral anticoagulants or the direct oral anticoagulants, but up till now there is no guidelines that recommend or prefer even the usage of novel oral anticoagulants over the vitamin K antagonists in cancer patients who had DVT. This is as far as I know. The second thing is the pregnant females or lactating females. In this situation also you can't give, it is completely prohibited to give novel oral anticoagulants. نقطة الاي ان ار والعيان المهمل، كل الترايلز اللي اتعملت as regarding, let me speak about the atrial fibrillation patients because these are the patients who took the drug for a long time in the trial that reaching up to 2.5 years, and they do the time in at which the patient is still in the INR between 2 and 3, which is the eligible number that make the patient safe from having a stroke or DVT pulmonary embolism. And in the last European Society of Cardiology guideline, they recommend that time in therapeutic range should be more than 70%. The patient should be more than 70% of his life between 2 and 3 to be safe from having stroke or DVT pulmonary embolism when we are speaking about these situations. And they found that although these patients who are inside these trials and they are closely monitored, they didn't reach to these numbers. And this makes the guideline, the European guidelines in 2016 to change these guides to make it as high as possible. And they do not recommend any figure 70 or more, because in these trials we couldn't find that patients on vitamin K antagonist reaching to the time in therapeutic range. So what about the patients who are outside the trials, who are dealing with himself? The time in therapeutic range, of course, it will be lower than these numbers, and so he will be more susceptible for complications rather than stroke or DVT pulmonary embolism.
شكرا دكتور احمد. It's clear. Again I have to confirm we have brainstormed our minds. Debates are being issued in this session. Multiplicity again doesn't mean that none is ideal. No, multiplicity means we have different tools to fight VTE by different ways according to individualized situations. I have to conclude this session. We have still the last session with many articles, great talk about the use in lymphatics. Dr. Muhammad Mahdaw will talk about the renal cell carcinoma. Now we have to switch our chairman. Thank you for my co-chairman, and I would ask for the next session chairman. Please stick with us. We have so many interesting talks on the oncoming session. Thank you very much.
Salam alaikum, good evening, bonsoir, schönen guten Abend.
New treatment concept, circade.
Good evening. Salam alaikum. So, I'm going to make it fast because I have 50 slides, but I know it's getting late now, so I'm trying to do my best to get it quite fast. So about MEDI, I'm pretty sure that, thank you. About MEDI, I'm pretty sure that most of you know MEDI very well. As a leader worldwide in the field of compression, or serial compression, very well known, especially in this field, since 1951. Beside that, MEDI is of course also very involved in the field of orthopedics, braces and soft supports for any part of the bodies that can get injured. Also in the hospital field for anti-embolism compression stockings. In the field of wound care with wonderful, beautiful products like Mediven Ulcer Kit or...
Excuse me, sir. Hold for a moment, please. Please be silent, please. We cannot hear the speaker, please. We should have a seat, please, sir. Dr. Ihab, Dr. Hisham, please have a seat. Thank you. Yes. I'm sorry. You can continue.
No problem. Thank you. Well, so as I said, beside the field of compression, for which MEDI is very well known since 1951, we're also in the field of wound care with beautiful, wonderful products like Mediven Ulcer Kit or Circade Juxtacure, but also hospital, I just mentioned anti-embolism compression stockings as well, like Trombexin or Struva. And last but not least, now also for a couple of years in the field of foot care, with ready-to-use insoles, but also customized insoles. So just to give you a brief overview about MEDI, I will squeeze a couple of slides just to save some time. Okay, so now let's go to our main topic for this presentation, which is about lymphedema and its usual standard treatments and what can be improved in that field, and maybe new approach in the treatment of lymphedema. So it's about CRCADE and how CRCADE by MEDI can improve the therapy outcome, the quality of the therapy, and the quality of life of the patients. So there is a short story about that, but maybe I will squeeze it as well. Just very quickly, on the left side, you see the inventor of CRCADE, Frank Shaw, and his wife. And also there is a short story on the giraffe that you see on the right side, but I will come back to that later. Sorry. Here you see typical indications for different kind of compression therapy which we are confronted to in our daily business life. And yeah, when you go on the right side of the pictures, then you have more the lipodema and lymphedema, for which we use traditionally, of course, the bandages. And inelastic compression compared to elastic compression, like medical compression stockings, which is more used in phlebology and venous disease. So, but is it the right thing to use only bandages in lipodema, lymphedema patients? This is the question we have today. We face and see a lot of challenges and a lot of difficulties when it comes to standard bandages. For example, do I have the right compression? How can I make sure that I have the right compression? That's one very big challenge. Then the time. Bandages, of course, are very time consuming. Is it comfortable for the patient to wear those bandages all the time and to be dependent on the therapist? The loosening. I mean, best case, just coming back to the first challenge with do I have the right compression? In the best case that I had the right compression, I will reach, of course, very fast a strong reduction of volume in the first stage of lymphedema patients. And then what will happen with the bandages? Of course, they will slide, they will slip, they will slip down, they will fall down. And then you face the loosening of the bandages and you need to do it again. The medical professionals, base case, they are well trained and very used in that field, and they can do it well. Again, base case, which we do not have all the time. But the patients are dependent on the medical professionals. They can't manage most of the time the bandages by themselves. Another challenge is the hygiene, a very important point. Because how do you take care of the skin? How can you wash the skin when you have the bandage? And it was very difficult and time consuming, so you don't want to get rid of the bandages just to take care of the skin. And then last but not least, the money factor. On the long run, even if at a glance it looks like maybe an economic alternative, it's not necessarily very economic on the long run. So also, last but not least, also what you see below on the last slide, we have some studies that have shown that the inelastic compression with the bandages is very often poorly applied. And the correct bandage application was performed only by 10 to maximum 60% of examined health professionals. So you can imagine in all the cases that it was, in many cases, not all, sorry, that it was unfortunately almost useless because they did not have the right compression. So that's how, coming back to the picture that you saw before of the inventor of CRCADE, Frank Shaw, he came to the idea. You saw also his wife on the middle, and his wife was actually suffering from lymphedema, and he could not stand watching his wife suffering from this disease and just doing nothing. So he said, and finally he had this very great and brilliant idea to think about something similar in terms of characteristic to the skin of the giraffe. Why? Simply because you probably never have seen a giraffe like on the right side. And this is due, and even if the giraffe stands 24 hours a day, 7 days a week, 52 weeks a year, You have a very high pressure with 250 millimeter of mercury, and they do not develop lymphedema. Why? The skin of the giraffe is extremely inelastic. And this was the basis of the invention of Circade. Inelastic skin, therefore inelastic material. So now we come to the therapy concept, lymphology, and the first phase, which is the decongestion phase, the transition phase, the maintenance phase, which is the third one. So the Circade idea is of course an alternative to the standard short straight bandages that are used for lymphedema patients most of the time. But beside that, there is a big involvement of the patient themselves, and the compliance of the patients is very, very important in the treatment of the disease. And by using Circade, you can really empower the patients to take care themselves of their disease, and therefore there is a very strong promotion of self-management. And then you can, of course, reach higher compression levels due to the fact that you use inelastic material, and this is easier to tolerate by the patients. So you can work with higher compression levels. So it's instantly adjustable. You have a perfect fit for the post band. And a very important point is this BPS guide card, the built-in pressure system, which will enable you to measure the pressure that you are applying. So it will not be exact, but at least you will know if you are between 20 and 30 millimeter of mercury, or between 30 and 40, and so on. And this is really excellent, because by doing that, you simply put it on the black lines, and the patients can do that also by themselves and make sure they apply the right compression on the Circade JuxtaFit. All the options that are available, I squeezed that quickly. The self-management is clear. The decongestion phase is at the beginning, you use mainly the Circade reduction kit, because this is where you will have a very strong reduction of the volume. Then you have the transition phase, where you use mainly the JuxtaFit. Here you can see the foot options. All the hand options that are available as well. As I've just said before, the volume reduction is the first phase, the decongestion phase, and then the transition phase with the Circade JuxtaFit. And in the last phase, the maintenance phase, you don't want the lymphedema to come back or to grow again. And you can use either you keep on using the JuxtaFit, Circade JuxtaFit, or you can move to Mediven flat knit garments like 550, Mediven 550, and made-to-measure solutions as well. Here you do not expect reduction of volume anymore, or very, very marginal. I squeezed the rest because it's becoming a little bit technical, and the time has gone anyway. Some few cases. Here you can see even some ulcers that have been treated by using Circade in a very successful way. The benefits for the patients are very clear. Also, I didn't mention that so far. You can use those products day and night. And due to the fact that you can readjust the compression by using this BPS guide card, you can lower the compression at night, but still make sure that you have compression at night. So that means that you increase the success of the therapy at the end. And again, the compliance of your patients. Easy donning and doffing, it's very clear compared to standard bandages, or also compared to compression stockings as well.
Should wrap up, please.
So just to finish, the take-home message, whatever cases you will face in your daily life, those are different things. We always have a solution with the right and appropriate Medi product. Thank you very much. One last thing that I would like to add is that we are proudly represented by ITC company for many, many decades in Egypt. And if you want to know more about Circade, you are welcome to come whenever there is a break, whenever you have time, to the MEDI booth at this Congress on the exhibition. And the ITC team will be very, very pleased to welcome you there. Thank you very much.
Our next speaker, Professor Musad Suleiman, continuing on aspirin or half of the therapeutic dose of wax for 1 year reduces the risk of recurrent DVT.
الحقيقة أنا عارف اليوم طويل وعشان كده أنا هحاول أكون as concise as I can. أجهدنا في خلال اليوم المليان بالمادة العلمية السرية. الحقيقة ديت one of the studies اللي عملناها عشان نشوف هل ممكن العيان بتاعنا اللي عنده DVT وخلص الثيرابي بتاعه 3 شهور أو 6 شهور، يا ترى نوقف العلاج مرة واحدة كده ونقول له خلاص انت بقيت زي الفل، ولا في حاجة لازم هنعملها؟ اللي هيقول الكلمة الفصل في الموضوع ده هو الستاديز اللي اتعملت. الموضوع ده ماشي ازاي؟ احنا بنلاقي ان VTE هو ده كرونيك ديزيز، ما هوش بعد الاكيوت ايفنت بقى كرونيك ديزيز، لان الموضوع it tends to recur after an acute event، فطالما بيرجع يبقى ده كرونيك ديزيز. الكاميولاتيف انسيدنس اللي متسجله في العالم كله 8.5% بعد 6 شهور بيرجع الدي في تي، 17.5% بعد سنتين، 24% بعد 5 سنين، و30% بعد 10 سنين. يبقى معناها نسبة الرجوع بتزيد مع كل وقت العيان بيمضيه، كل ما بنلاقي ان في دي في تي بتعلى. الهازارد ريت ده بيتحسب بقى ان انا كل عيان عندي البوسيبيليتي لانه يجي له مشاكل اب تو ما نسميها ب ديزيز ريليتد ديس، يعني العيان ممكن كام او نسبته قد ايه اللي يموتوا من الدي في تي. بنلاقي ان الهازارد ريت بيبقى في اول 6 شهور ل 12 شهر بعد الفي تي اي ابيسود. الحقيقه الريت بتاع الريكارنس ده بيقل لكن عمره ما بيختفي، يعني معناها ان اول مره فيرست ابيسود من الدي في تي منتين مع العيان والهازارد ريت بتاعه قائم والانسيدنس بتاع الريكارنس بيبقى لسه موجود. التريتمنت بتاع بالفيتامين كي انتاجونست قلل الريت بتاع الريكارنس بحوالي 80-90%، وبالتالي الريسك اوف ريكارنس بتريتمنت قل ب1 ل 2% لكل سنه. لكن بنلاقي ان التريد اوف فور ذيس ريماركابل افيكاسي بيبقى ديبندنت على الريسك فور بليدنج كومبليكيشنز، النيد فور اللابوراتوري مونيتورنج والدوز ادجستمنت. معظم العيانين بيتعالجوا من الفي تي اي لمده 3 ل 12 شهر، وبعدين في مجموعه بتبقى indefinite treatment for selected patients، وبنلاقي ان الانتي كواجولانس بيبقوا discontinued لما بنلاقي ان العيان موضوع الريسك اوف بليدنج اجينست الريكارنس ريت انا اللي بوزنها، بقول ان العيان ده عنده لو كملت على العلاج الريسك اوف بليدنج يعلى فيه، ولا لو وقفت العلاج الريكارنس ريت هيبقى عالي فيه. After cessation of anticoagulation therapy, recurrent venous thromboembolism is a major clinical problem. مفيش therapy so far with an acceptable benefit to risk ratio is available for long-term management. بالرغم من ان الاكستندد يوز من الفول دوز وارفرين كان associated مع reduced rates of recurrent venous thromboembolism، لكن طبعا بنلاقي ان الكوميونتي بيزد ستاديز لقت ان الابروتش ده بيبقى associated with a substantial risk of major bleeding. يعني لما كملوا على الفيتامين كي انتاجونست لفتره طويله الريسك اوف بليدنج علا عند الناس دي، فبالتالي موضوع البالانس ده قائم. مثلا في اوبزرفيشنال ستادي لقت ان الفول دوز من الورفرين كان associated with rates of major bleeding حوالي 5 ل 9%، وفي الانيوال ريت اوف ميجر هيموريج كان 3.8%. دي ارقام الحقيقه عاليه. عاوز اختصر بسرعه، دي ستاديز اتعملت على اللونج تيرم انتي كاجوليشن في الثرومبو امبوليز، وكان معظم الكلام على الفي كي ايز وازاي تستخدمها لفتره طويله. بعض الناس قالت يا ترى هم 3 شهور فيرسس 1 يير نقول احسن، وبالتالي برضو كان الانسر مثلا دي واحده من الاستاديز اللي اتعملت على على الحالات اللي هي امبروفوكد دي في تي، وادوا للعيانين الثيرابي لمده ال3 شهور. بعد ال3 شهور من الفول انتي كواجوليشن ثيرابي عملوا ايه؟ راندومايزيشن للعيانين تاني، مجموعه ما خدتش حاجه خالص ومجموعه بداوا ياخدوا كونتينيود انتي كواجوليشن ثيرابي. ايه اللي حصل؟ اللي حصل ان من اول الشهر الثالث لحد الشهر ال12 لقوا ان الريكارنس ريت في المجموعه اللي خدت انتي كواجوليشن كان 0.7%، اقل من 1%. المجموعه اللي ما اخدتش كانت النسبه 8.3%. يبقى ده بيديك قد ايه الفكره ان لما كونتينيو على انتي كواجوليشن بعد اول 3 شهور في الناس اللي هم الامبروفوكد الانسيدنس اوف ريكارنس قل في العيانين دول. طب مع بعد ال 12 شهر continuation on anticoagulation does it achieve more effect؟ يعني بعد الشهر 12 هكمل. الحقيقه الاستادي قالت غير كده خالص، قالت ان بعد الشهر ال 12 continuation on anticoagulation is associated with a similar risk of recurrence. يعني ايه؟ يعني الناس اللي خدوا واللي ما خدوش كان الريكارنس ريت فيهم 15.8%. يبقى هنا كان الكونكلوجن بتاعهم ايه؟ ان الانتي كواجوليشن loses its effect as a prophylactic agent after 1 year. ده كانت الكونكلوجن بتاعت الاستاديز، وده اللي هم قالوه في نهايتها. في نيو انجلاند جورنال اوف ميديسين كذا استادي على اليوز اوف لو انتنسيتي وارفرين. يعني ايه لو انتنسيتي وارفرين؟ انك تستخدم الوارفرين بط ان ا سب ثيرابيوتيك دوز، يعني ما تستخدمش بالفول ثيرابيوتيك دوز اللي تديك اي ان ار 2.5 ل 3 زي ما احنا عارفين، لا ده هتديك اي ان ار 1.5 ل 2، ده سب ثيرابيوتيك ويكمل عليها فور ا مينتيند ديوريشن. كان الريدكشن بتاع الريسك اوف ريكارنت فينس امبليزم بتوين 76 to 81%، وده كان الكونكلوجن بتاعهم ان انا هدي 10 عيانين anticoagulation for 3 years to prevent 1 recurrent event. Do you know the magnitude of this situation؟ 10 عيانين هديهم anticoagulation عشان امنع recurrence في عيان واحد. ده كان الكونكلوجن في نيو انجلاند جورنال اوف ميديسين. The same for the other studies. وبالتالي احنا عاوزين نقول ايه اللي احنا عملناه هنا؟ الحقيقه عملنا a bimodal descriptive analytical study اتعملت على 832 عيان عندهم في تي اي. البيشنتس كانوا مجموعتين، 50% كانوا ماشيين على الانتي كواجوليشن من سنه 2002 ل 2013 وده اتحسبوا ريتروسبكتيف كان على الفي كي اي. المجموعه الثانيه كانوا حوالي برضو 50% على الاذر سايد، ودول خدوا انتي كواجوليشن ويزر بالاسبرين او بالدواكس. الداتا بتاعتنا قالت ايه؟ ان كل العيانين يتعالجوا لمده ال3 شهور ل6 شهور في الانيشال مود اوف ثيرابي. بعد كده بعد 12 شهر في الامبروفوج بيشنتس كان عندنا 348 ميل و384 فيميل، وفي الجروب ايه البيشنتس كانوا مينتيند على الاسبرين بس. يعني بعد ما خلصنا ال3 شهور ل6 شهور مجموعه خدت اسبرين بس، وكمل الاسبرين بتاعهم لمده سنه، والاستادي كملت اللي مشوا على الاسبرين لمده 88 شهر. ده اطول مده، لكن الافريج بتاعهم كان سنه. في الجروب بي المجموعه ديت اخذت دواكس، واخذوا الدواكس بهاف دوز. يعني اذا كنت بدي الابيكسابان ثيرابيوتيك ديز 5 ملغ توايس ديلي، بديه 5 ملغ اونلي وانس. ريفاروكسابان بديه وانس.
اللي هو 10 مللي جرام، او اذا كنت بدي من الدابيجاتران 110. المجموعه ديت لقينا فيها ايه؟ الدي في تي كان 80% من الحالات كان ريسنت، يعني في خلال شهر من الاتاك اتعالجوا. 80% كان الاتاك في خلال شهر. 20% من الحالات ديت كان في بعد شهر، يعني شفناهم بعد شهر الاتاك جات له. كان في 29 حاله بايلاترال دي في تي ويز بالمونري امبوليزم في الاستادي كلها. الانبروفوكد كان اعلى قوي زي ما انتم شايفين هنا، ان الانبروفوكد كان حوالي 77%، البروفوكد كان حوالي 22%. البروفوكد كان يا اما نتيجه لبوست بارتم او بريجنسي او سيرجري او تروما او امبولايزيشن. الاستادي عاوز الخصها بسرعه، ان احنا لقينا الشكل اللي قدامكم ده. ايه اللي كان عندنا؟ لقينا ان الحالات اللي مشت على الفيتامين كي انتاجونست حصل فيهم ريكرنس 13.3%. الناس اللي مشت على الدواكس الريكرنس ريت كان 7.4%. اللي اخدوا فول دوز واللي اخدوا هاف دوز الاثنين كانوا ايكوال في الريكرنس، ما كانش في فرق بين الفول دوز والهاف دوز، خلي بالكم. الحاجه الثانيه اللي مشوا على لونج تيرم من الدواكس لمده سنه، يعني خدوا نص الجرعه لمده سنه، الريكرنس ريت هاف بين ريماركابلي ريديوزد تو 3.7%. اوه ماي جاد، ده انا حاولت طيب 10 minutes. استاذ الدكتور محمد عشان انا خلاص هعمل كونكلوجن على طول اهو. المجموعه اللي خدت اللو دوز اسبرين كان الريكرنس ريت فيهم نص 5.5%. الحقيقه انا عايز اوصل بسرعه وهقول لكم هعدي حاجات. زي ما انتم شايفين اللونجر ديوريشن كان 96 شهر، وعلى الاسبرين كانوا 88 شهر. شوفوا بقى النقطه دي، بصوا الريثرومبوزيس ريت في العيانين اللي اخدوا 3 شهور ل6 شهور الريثرومبوزيس ريت كان 11.7%. العيانين اللي اخدوا اكستندد ثيرابي ووصل لسنه الريثرومبوزيس ريت 10% قل. اللي مشوا على الدواكس بهاف دوز الريكرنس ريت 3.7%. اللي مشوا على الاسبرين 5.9%. الحقيقه دي ارقام رائعه. وعلى الاستادي دي لاحظوا بقى الحاجه الثانيه، ان احنا عملنا انترتشينج فروم وان دواك تو ذا اذر، واحنا كنا بنسير النقطه دي من شويه، يا تستخدم واحد وتنقل واحد تاني وهكذا. شوفوا العيان اللي مشي على سنجل دواك اونلي وان ميديسن، ايه اللي حصل؟ الريكرنس ريت فيهم كان 5.8%. اللي مشوا على دبل، يعني نقلت من واحد للتاني، الريكرنس ريت قل بقى 1%. اللي مشى على 3، يعني ايه 3؟ يعني اديته ريفرسابان وبعدين لقيته مش مناسب في حته معينه رحت ناقل على ابيكسابان وبعدين نقل، فاخدوا 3 المحصله الريكرنس ريت قل فيهم. يعني انت عاوز تقول ايه؟ عاوز اقول ان الدواكس ار انترتشينجبل، اقدر انقل من واحد للتاني للتالت بدون ما ياثر. لا، ده حسن لي النتيجه في ان الريكرنس قل، وبالتالي وصلنا للكونكلوجن دي ان الانتي كواجولانس سواء في كي اي او نواكس ده لازم تديها على الاقل 3 شهور. كل الاستاديز اللي ادت اقل من 3 شهور كان النتائج بتاعتها في ريكرنس عالي قوي. الحاجه الثانيه البروفوكد لازم تكمل 6 شهور اور ايفن مور. اللونج تيرم دوز من الدواكس او الاسبرين especially in unprovoked cases significantly reduces the risk of recurrence and new attacks من ال VTE without increasing the bleeding risk. And lastly, DWACs are interchangeable, and changing from one to the other even reduces more because they act at different mechanisms of action. Thank you very much.
And now I will introduce one of our colleagues in Cairo University with known expertise in endovascular surgery, especially venous endovascular surgery, Dr. Mohammed Al-Maddaw, Professor of Vascular Surgery, Cairo University, to present a case of renal cell carcinoma with level 4 inferior vena cava tumor thrombus.
evening again. I'd be too short. I would like to thank Professor Dr. Omar for his nice introduction to me. The incidence of the renal cell carcinoma new cases in the year 2012 was 56,000 cases, with 12,000 of cases of mortality, and about 5% to 10% of the cases there were an involvement of the IVC. The complication rate, which amounts to 38%, in the first is the mortality and pulmonary embolism, wound infection, and re-intervention. The staging, this is according to the American Joint on Cancer Committee, which was published in 2010. Involvement of the inferior vena cava is classified as a T2B, and when it involves the main renal vein, and it is T3C if it involves the inferior vena cava. That's to mean this is a locally advanced tumor. There is also for its level a lot of classifications. The one which will be conducted here is the Novick classification. This is the level 0 when it is confined to the renal vein. When it extends for only 2 centimeters in the inferior vena cava, it is the level 1. And when it reaches up to the hepatic veins, it is level 2. In the IVC below the diaphragm, it is the level 3. And if it extends to the IVC above the diaphragm or into the right atrium, is the level 4. In the imaging techniques, the ultrasound, being operator dependent, has the least sensitivity. It reaches 68%. MRI is now the modality of a choice, with the sensitivity is 100%. The CT has a sensitivity of 83%, but when we use the multi-detector CT, it reaches 98% specificity. And if you combine both modalities to each other, you should consider the timing for that, which should not be more than 14 days because of the dynamic change in the patient course. The TEE is transthoracic echocardiography, being invasive, is reserved to the intraoperative management of such cases in order to ensure the clearance of the thrombus. This is a picture during our case, and this is the mobile part of this. This is the thrombus inside of the right atrium. The surgical expertise in this, in the level 0 neurosurgery can perform it. Level 1 and 2, the neurosurgery plus the vascular surgery. Level 3, we should call for the hepatobiliary in addition, and for the level 4 is, of course, the cardiothoracic surgeon will be attending. In the level 0 and level 1, the flank versus chevron incision are the preferred by most of the publications. And in the level 2, the chevron intraperitoneal incision. Level 3 and 4, chevron is preferred plus median sternotomy. The level 4, the involved surgical team was the anesthesiologist who should put a plan for this patient and how to perform a resuscitation for him, and how to do the monitoring, good monitoring for him, and also to ensure the post-operative pain-free period. The neurosurgery, of course, and the vascular surgery, cardiosurgery, and the perfusionist, which should elect between doing to the patient cardiopulmonary bypass plus or minus deep hypothermic circulatory arrest, or veno-venous bypass, as in our case we elected to do that. The patient position was supine position, and the incision was the chevron incision plus median sternotomy incision. After doing the chevron incision, abdominal expression was conducted, and right medial visceral rotations was performed in order to expose the inferior vena cava. Ligation and division of the right renal artery was performed together with ligation division of the right ureter, and then we controlled the left renal vein as shown in the picture. Also, it had been published in the literature that if you find that the IVC is dilated, this indicates that there is some degree of tumor invasion inside of the wall, which is an ominous sign for the process itself. Then this was followed by median sternotomy. As shown, this is the pericardium, which is still intact. Veno-venous bypass was performed as shown there, and there is incision of the right renal vein in order to manipulate the thrombus, then followed by the incision of the right atrium as shown in this picture. This is the thrombus. This is the thrombus, the tumor thrombus here, and this is the edges of the right atrium has been opened, and this is the cardiosurgeon tried to milk it out. Then there will be extirpation of the tumor thrombus issued thereafter. Closure of the arterial of the atrial incision was performed. Division of the right renal vein flush with the IVC. Extirpation of the right kidney was performed as you see here, and then repair of the IVC by 3,0 polypropylene sutures. This is the outcome. The mortality when there is an invasion of the IVC ranges from 5 to 10%, and complications rate 38%. Surprisingly, the IVC thrombus level has no effect on the overall survival of such patient. But there are other factors which can be grouped into preoperative and postoperative. In the preoperative, one is the nutritional status. Good nutritional status had 85.4%, and the disease of survival, and the disease-free survival of 94%. This figure decreased by almost 30% when the nutritional status is deficient. Also, the presence of the comorbidity. Suspicion of the lymph node metastasis has also its impact, and suspicion of the distant metastasis. The post-operative TNM staging, tumor differentiation, nuclear aneuploidy, lymph nodes involvement and distant metastasis, and also the response of the patient to the specific chemotherapy. Thank you.
Next speaker, Professor Hisham Sharaf, Mansoura University, will talk about new trend in the management of acute ischemia.
السلام عليكم. Now we will talk about a very important subject that we are all facing as emergency, and we're discussing this subject to reach the optimum management of these patients complaining of acute limb ischemia. As we all know that the acute limb ischemia is defined as the severely reduced perfusion of the limb from total or subtotal, due to total or subtotal occlusion of the vessel and dating less than 14 days. Patient with thromboembolic occlusion, especially of elder age, more than 75 years, are exposed to morbidity and mortality even after treatment. So the stages of acute limb ischemia is changed from acute or chronic ischemia to viable or critically or non-viable limb. For the viable limbs, it is the limb that maintain sensor and the motor and the anterior and venous flow is patent. marginally threatened or immediately threatened limb that needs intervention, and non-viable limb that needs amputation. This is the task classification of the acute or chronic limb ischemia as viable and threatened or non-viable limb. This is a picture of patient with class 2A ischemia and the class 2B critical ischemia. And this is the angiogram for the total thromboembolic occlusion of the aortoiliac lesion from our cases. And this is also the case of thrombosis of the aortoiliac lesion with the presence of the collaterals as we see. What the management of these cases? The management of these cases either these steps with heparin therapy, hydration, and revascularization. The revascularization may be surgical or endovascular or repair when there is trauma of the limb. The management protocol as European Society of Vascular Surgery for acute limb ischemia, if it is by presentation, the initial workup by duplex scanning and CT angio or DSA, viable presentation Rutherford 2 with urgent revascularization, and if it is irreversible, amputation will be done. Also, after doing the investigation, we must do revascularization by either surgical or thrombolysis. If it is critical, Rutherford 2 for underlying vascular lesion. If it is present, we do endovascular therapy. If it is absent, we maintaining for the medical therapy. And as we all know, if it is non-viable, we get to amputation. The initial treatment of intravenous heparin for stage 1 viable presentation after imaging, and stage 2A after imaging revascularization, and as my colleague Amr Shafi following for endovascular after angiogram in the theater. For stage 2B, also imaging and not delaying because of these cases, the time is counted for the preservation of the motor power and sense power of the patient. For the heparin therapy, the goals of anticoagulation to decrease the thrombus propagation and prevent the complication or recurrence of the cases. Using unfractionated heparin as a bolus dose, 100 units per kg, and continuous infusion as 20 milligrams per kg per hour. Immediate after diagnosis, we taking blood sampling to search for the head or head thrombosis. For revascularization, surgical embolectomy, in most of the cases nowadays in the theater, if there is no backflow enough, we doing completion angiogram to make the definitive treatment for this patient without any delay. Using overwire casters like overwire Fogarty caster, and further intervention for clearance of the circulation and making the definitive treatment for this patient. Bypass surgery, if there is complete occlusion not responding to Fogarty catheter or embolectomy, we're doing bypass either anatomical or extra anatomical in the same setting. Also CDT or versus thromboembolectomy. Caster-directed thrombolysis nowadays helping for clearance of the circulation, especially in delayed patient. So it gives excellent results for mild to moderate limb ischemia. CDT often used in the setting of thrombotic occlusion and has slower return to arterial flow, so it reduces reperfusion injury. Thromboembolectomy usually used in large vessels and for embolic occlusion. So you must weigh or balancing the situation for using CDT intraoperative. With pros and cons for this intraoperative thrombolysis, it is adjunctive or adjuvant to surgical thromboembolectomy to clear the residual thrombus, but it is inadequate in some patients with extensive distal thrombosis. Operative thromboembolectomy to clear the vessel wall, and after that we do repetition of the dose for 20 to 30 minutes infusion intraarterial by infusing lytic therapy. The high dose for isolated limb perfusion, we can using manual infusion or partial bypass with pump oxygenator. What is the endovascular option for this patient? No role nowadays for systemic thrombolysis anyway for the patient with thromboembolic occlusion. Catheter direct thrombolytic therapy, initial choice in class 1 and class 2A patients, may in more advanced degree of ischemia, and the advantage it reduces the endothelial trauma and making clot-lysis and the gradual clearance of the outflow, so it prevents the presence of reperfusion injury. Fibrolytic dosage, there is more or different schools for the dose of lytic therapy. It is ranging from 0.02 to 0.1 milligram per kg per hour, or 0.25 to 1 milligram per hour for maximum 2 milligram per hour, or in cases some using interrupted dose for 3 milligrams for 5 to 10 minutes, then 0.05 milligram per kg per hour. Duration of ZTT, usually the duration is 48 hours, and commonly CTT is continued overnight for 6 to 12 hours. And the heparin during CDT, usually we doing intravenous or intraarterial through the sheath. A bolus dose at the time of thrombolysis is not recommended, and the infusion rate to raise the BTT to only 0.25 to 1.5 of control. The recommended dose is between 200 and 500 units per hour. This is the crossover technique. And the endovascular thrombectomy using percutaneous aspiration or percutaneous mechanical thrombectomy or combination with CDT. This is the percutaneous technique for removal of the thrombus. This percutaneous mechanical thrombectomy has also the advantage and disadvantage. The advantage is disrupt the thrombus and allow better penetration of the clot by the lytic agent, so it decreasing the dose and also decreasing the time for lysis of the thrombus. But it can be used only in large vessels, and the device is expensive. This is the drawbacks of this one. The mechanical thrombectomy, we have different devices like Trellis or Angiojet or Aspirex or Retarex for the solution of the thrombus and the making the lytic therapy to contact with the thrombus. This is the case using thrombolytic CDT with mechanical thrombectomy, and this is after clearance of the circulation from the thrombus. This is another case. The most recent is the continuous aspiration mechanical thrombectomy catheters, which is called CAT. And this catheters has different diameters from 3 to 6. And it is easy for application, and it can be used for percutaneous aspiration of the thrombus. This is a different type of manual thrombus aspiration by different catheters. The strategy of minimizing the mortality, we usually recommending to do fasciotomy for late presentation or patient coming late with acute ischemia. So the fasciotomy is mandatory for this patient to protect the muscles and protect the kidney from reperfusion injury, as it affecting most of the patient complaining of delayed acute ischemia. The summary of this, the ischemia reperfusion injury due to calcium overload and the pH recovery and the overproduction of oxygen strands that making injury of the cells and death of the muscles. The manifestation of reperfusion injury, there was like vascular injury, myocardial shunting, and reperfusion arrhythmia. Therapeutic strategy for prevention of the injury, ischemic preconditioning, antioxidant therapy, anti-complement therapy, and anti-leukocytic therapy. This is the most recent for prevention of the reperfusion injury. The antioxidant therapy and the anti-complementary therapy, and also, sorry. My conclusion is the completion angioplasty should be essential. Intraoperable thrombolysis only in thrombotic case, class 1 and class 2. CDT is controversial in delayed cases, and BMT, pharmacomechanical thrombolysis, considered in large vessels, and it is useful in type 2B. Timely, the reperfusion of ischemic area at risk remains the cornerstone for clinical practice. Therapeutic strategy may be significantly prevent and limit reperfusion injury. Thank you.
Our next speaker is Professor Jamal Zakaria, Professor of Anesthesia and Intensive Care, Mansoura University. He will talk about percutaneous radiofrequency ablation.
Mr. Chairman, and a great thanks to Professor Dr. Musad and my colleagues and the professors in vascular surgery department. The need for sympathectomy is indicated for many conditions as hyperhidrosis, complex regional pain syndrome, and other peripheral vascular disease, and sympathectomy was routinely done by endoscopic thoracoscope under general anesthesia. Recently, with the introduction of radiofrequency ablation, percutaneous sympathectomy can be achieved under local anesthesia in outpatient clinics. And in these topics, our objective is to demonstrate the radiofrequency machine, modes, mechanism, procedures, and indications, anatomy of sympathetic chain, physiology and pharmacological aspects, endoscopy versus radiofrequency. Radiofrequency is used for over 3 decades for management of various conditions as complex regional pain syndrome and many vascular disease. This is the radiofrequency machine, which is formed of the temperature display, impedance monitors, stimulator, and lesion generator. Electrical stimulation, sensory stimulation confirm proximity to the target, and the motor stimulation confirm a safe distance to a motor fibers in case of heat lesion is made. Type of lesioning modes, continuous radiofrequency and pulsed radiofrequency. Continuous radiofrequency, an electric field is established around the electrode tip. This field oscillates with alternating radiofrequency current, causing movement of ions in the tissues. This causes friction in the tissues around the catheter tip, which produce heat. cells become damaged at 40 degree and they become near induction at 60 to 100 degrees, induction of protein coagulation leading to cell death. While pulsed radio frequency is non-destructive, it is safe, no reports of morbidity. You can use it in areas you would not want to heat as the peripheral nerves and dorsal root ganglia. It is easier on the patient. All of us know that the sympathetic nervous system is considered for fight or flight or fright, and the norepinephrine is the neurotransmitter released by postganglionic fibers, while acetylcholine is in preganglionic fiber. Anatomy of sympathetic exchange: preganglionic axons exit from the spinal cord through the ventral root and enter the spinal nerve, exit the spinal nerve via communicating rami, and enter the sympathetic trunk where the postganglionic fibers synapse on the postganglionic neuron in the chain ganglion, then return to spinal nerve and follow its branches to the skin, or ascend or descend within the sympathetic trunk and synapse with the postganglionic neuron within a chain ganglion and return to spinal nerve at the level and follow branches of the skin. One of the common cause of recurrence is for the sympathetic chain is while the sympathetic chain pass through without synapsing from a splanchnic nerve that pass towards the thoracic or abdominal organs. These synapse in the vertebral ganglion in front of the aorta. Sympathectomy physically destroys the relevant nerves anywhere in the sympathetic trunk, which are long chains of the nerve ganglia located bilaterally along the vertebral column. Three regions: cervical or thoracic or lumbar. First, we discuss thoracic sympathetic trunk, which is comprised of 11 ganglia, of which is the first fused to inferior cervical ganglia to form stellate ganglia. Upper 10 ganglia lies outside the parietal pleura against the head of the ribs, while the lower 2 ganglia lies on the sides of the body of corresponding vertebrae. T2 and T3 roots contains most of the vasoconstrictor fibers to the upper extremity, while the axillary sympathetic innervation derives from T4 and T5. The sympathetic outflow to the cilia muscles and the pupillary constrictor of the eye is from T1. The knowledge is important to prevent Horner syndrome, which is ipsilateral ptosis, meiosis, and facial anhidrosis. One of the important criteria for recurrence is Crohn's nerve, which is the interthoracic nerve, which arises from T2 and bypass the sympathetic chain to the lower brachial plexus. Crohn's nerve arises من السمباثيك number 2 and يعني بيبقى arise lateral, فيعني we must ablate the lateral position of sympathetic 2 to avoid the Crohn's nerve. Our technique for radio frequency: the patient will be in the prone position after complete aseptic technique and sedation. Temperature probe should be placed on the corresponding hand for continuous monitoring. C-arm will be centralized in the posterior anterior position. End plate of T2 and T3 will be aligned by cephalocaudal rotation, then lateral tilt by about 10 to 15 degrees. Radio frequency cannula will be advanced to T2 and T3 sympathetic ganglia, which is hidden behind the head of the ribs. This is a fluoroscopic image seeing for lateral position. Lateral view showing the needle tip above the foramen at the posterior part of the middle third of the vertebral body. Temperature probe placed on the corresponding hand for continuous monitoring. The rise in the skin temperature of at least 1 degree confirms the neurolysis of the sympathetic chain. Indication of sympathectomy: peripheral vascular disease, hyperhidrosis, relief of pain in refractory angina and causalgia and reflex sympathetic dystrophy. This is a paper done in 2011 in European Journal of Cardiovascular Surgery. He takes two groups, group endoscopic thoracoscope and group radiofrequency, and the conclusion was endoscopic surgery was a gold standard for thoracic sympathectomy with fair results in radiofrequency. Another paper in 2013. He takes him group, one group for surgical sympathectomy and another for radiofrequency. He found the results was 95 in surgical group and 75 in the radiofrequency group. This paper added the alcohol for the radiofrequency group to increase the efficacy, and he reached to 85%. Alcohol is intensely painful during injection, so the large volume of local anesthetic drug is injected prior to alcohol. It is hypobaric, water soluble, and spread rapidly from injection site, so large volume is required. The incidence of neuritis is very high with its injection. عشان كده بنستخدم دوز كتير قوي مع السترويد. This is the clinical trials of our current research. We trying to adding phenol instead of alcohol to increase the efficacy and decrease the complication of neuritis. Phenol is a local anesthetic agent at lower concentration and become more neurolytic at higher concentration. It is not painful, and it is prepared in a mixture with glycerine, which is highly soluble, hyperbaric, and it diffuses slowly into the local tissues. Phenol diffuse into the axons and perineural blood vessels, denaturate the protein with a relative sparing effect on the dorsal root ganglia. Also, radiofrequency can be used in regional pain syndrome and Raynaud's disease. Why using radiofrequency? Radiofrequency is a safe and minimally invasive, inexpensive, non-surgical, done in outpatient setting, no need for general anesthesia, post-operative pain and respiratory problems are less than sensory, early return to normal daily activity. While endoscope requires surgical expertise, which might not be available in every situation. In addition, endoscope poses a significant challenge to anesthetists because of using of one lung anesthesia and double lumen tube. Many patients are young and refuse to undergo this surgery. Complication of thoracic radiofrequency, recurrence, intercostal neuralgia, pneumothorax, injury to subclavian vessels and esophagus are also reported. compensatory hyperhidrosis، الحقيقة احنا وجدنا الكومبنساتوري هايبرهيدروزس في الريسيرش بتاعنا حوالي 10%، يعني قليل جدا. الجروب بتاع السيرجري يعني كانت above 60 unexplained cause يعني. Also, radiofrequency can be used in lumbar sympathectomy. There is a lumbar sympathetic trunk on each side, lies retroperitoneally, lies in the anterolateral surface of the body's lumbar vertebrae along the medial margin of the psoas major muscles. On the right side of the trunk overlapped by inferior vena cava, while on the left side is overlying by aorta. Usually there is 3 lumbar ganglia, lumbar 1 and 2 and 3. Sympathetic to a normal limb, increase in the blood flow, increase the efficacy of collateral circulation, and alteration of pain impulse transmission. Indication of lumbar sympathectomy, causalgia, symptomatic vasospastic disorders, hyperhidrosis, inoperable arterial occlusive disease with limb-threatening ischemia and phantom limb vein. Lumbar sympathectomy can be used safely and effectively in lower limb hyperhidrosis. Sensory stimulation confirm proximity to the target. Motor stimulation confirm a safe distance to motor fiber, so genitofemoral nerve is safe. Also, radiofrequency can be used in compensatory hyperhidrosis, in Raynaud's disease, Berger's disease. Advance of radiofrequency in lumbar sympathectomy, sensory stimulation confirm proximity to the target, motor stimulation confirm a safe distance to motor fibers. In case of heat lesion is made, so the genitofemoral nerve is safe. This is a fluoroscopy image for the technique of lumbar sympathectomy, anteroposterior and lateral. Some complications of lumbar failure, post-sympathetic neuralgia, and sexual problem, which is very minimal. Take-home message: radiofrequency sympathectomy is a promising method for chronic pain disorders. vascular insufficiency as renal disease, Berger's disease, and hyperhidrosis. Percutaneous radiofrequency mastectomy is a new minimally invasive procedure, non-surgical, safe, inexpensive, and done under sedation with local anesthesia in an outpatient setting. Thank you.
بسم الله الرحمن الرحيم. في حد هنا؟ السلام عليكم. يعني اسمحوا لي to take you to a sailing a process to a far island for an ignored topic, which is fungal infections in diabetic feet patients. Is it important topic or no to be ignored? If we have a look, we have about 360 million diabetics. About half of them has wounds or ulcers in the feet, and about another half of them are having superimposed infection. That will cause continuous morbidity and mortality for these patients, with very bad quality of life and frequent hospital admissions with more expenses and extra disabilities. And if we look for the fate, we'll see that there is amputation rate about 50% of these patients within 5 years only, within 5 years survival. That means half of the patient after amputation will die, and the other half will suffer from other events in the second limb. The pedal fungal infections, tinea pedis or onychomycosis, is not a big deal in normal patients, non-diabetics, which occurs in about 20% of people. But if this patient is elderly, immunocompromised, and diabetic, it will be a big deal. Almostly because it is misdiagnosis. We all ignore and forget this diagnosis, and also this infection is contagious. Contagious for the same food, contagious for the other food, and other persons also. So, what's the importance of this infection? It is high frequency of incidence, lack of its diagnosis, difficulty of treatment, risk of amputation is very high, and the risk of mortality also, if you can imagine. Why it is high frequency? We have about 1/3 of cases having fungal infections within the diabetic patients, and this incidence is higher within the patients having nail infections or skin infections rather than ulcers. And diabetic foot infection was found in 1/3 of patients as a sole infecting agent, or in combination with bacterial infection in other 2/3 of the patients. Also, the importance comes from the lack of diagnosis, that when you do regular culture for these infected cases, you cannot find or diagnose the fungal infection in only 5% of patients. But if you have selective culture for the fungal infection, which is called pan-fungal internal transcribed spacer 1, you can find 80% positive for fungal infection in the same patients. And again, it is difficult to treat because in a study they found that 65% of candida infections and almost 80% of Aspergillus infections are resistant to standard antifungal treatment. So traditional antifungal regimens are difficult to treat, especially in hyperglycemic patients, uncontrolled diabetes, and difficulty in maintaining hygiene, good hygiene for these patients, as they are having neuropathy or obesity or even retinopathy. So they cannot give a good care for their feet that make the infection is more severe and the control is more difficult. Why it is important again? Because there is unexpected risk of amputation for these patients is added due to presence of fungal infection. Because of presence of Tinea pedis, onychomycosis, that increases the risk of resistance and the risk of amputation later on. Why? Because presence of fungal infection, either dermatophytic or non-dermatophytic infections, causing superimposed infection by bacteria, especially these patients has diabetic neuropathy, vascular insufficiency, and onychomycosis that causing thickening of the nails, irregularity of the nails that will add more mechanical trauma to the tissues and more infections, more fissuring, and more devitalization of the skin that cause cellulitis or even osteomyelitis up to gangrene and amputation later on. This risk can cause, as I said, fungal osteomyelitis, if you can imagine, and even fungal tenosynovitis in very peculiar aspect of patients that was proved by a study. They found that 1/3 of the patients of amputated ones, they calculated the odds ratio in these cases, and they found that the highest odds ratio in the subgroup of patients, they are those with fungal infection. It's 10 point something, causing amputation. We can go further, not only for amputation, but likewise for mortality, as opportunistic fungal infections in such patients can go for systemic infections and mortality. In which subgroup of patients? In uncontrolled diabetics, in debilitated patients, hemodialysis patients, HIV patients, hepatic patients, cancer patients, transplanted patients, hospitalized patients. They found that there is very high incidence of intra-hospital trans patients' infection by fungal, especially the Candida auris. Candida auris, this category was diagnosed lately in 2017 in USA and caused very high incidence of patients' mortality. And they can separate it by cultures, and it's named Candida auris. So, after this introduction for the importance of such infections, we have to agree that the prevention, identification, management of fungal food infections is very important. So we have to put strategies for prevention for such patients. The first is to evaluate the patient as a whole, the affected limb and the wound in the foot, and classify the infection in the foot by extension and depth. And this is a classification we all know that by the Infectious Diseases Society of America. They classify the wounds, and